Greetings everyone. Today's talk is on edema. How edema can compromise healing of surgical wounds. Patients with edematous tissues may be secondary to congestive heart failure, renal failure, or as part of a SIRS syndrome in very sick patients. Edematous tissues operated on can lead potentially to postoperative wound dehiscence and other complications. And also how edema compromises healing by secondary intention of wounds on lower extremities or wounds in other locations. And I'll use chronic venous insufficiency as an example. So let's very briefly talk about the exchange of nutrients from blood to the tissues, which happens at the level of the capillaries. At the arterial end of the capillaries, the blood flows into the capillaries and leaves at the venous end. At the arterial end of the capillaries, the blood has a hydrostatic pressure and the osmotic pressure. The hydrostatic pressure pushes the fluid out of the leaky capillaries and into the tissue spaces to form interstitial fluid which bathes the tissue cells. The osmotic pressure pulls the fluid back into the capillaries. So at the arterial end of the capillaries, the hydrostatic pressure is 35 millimeter of mercury. The osmotic pressure, due to components of the blood such as albumin, is lower, is 25. So there's net pressure pushing the fluid out, net pressure of 10 millimeters of mercury. So fluid leaks out of the capillaries and into the tissue spaces to form interstitial fluid. As the blood flows along the capillaries, it loses some of its pressure. So the hydrostatic pressure is now lower. It's about 15 millimeter of mercury. The osmotic pressure is more or less unchanged. So now there's net flow of fluid back into the capillaries and then back into the systemic circulation. Now, what happens in chronic venous insufficiency? We're going to use chronic venous insufficiency as an example of edema. In chronic venous insufficiency, there's increase in hydrostatic pressure in the venous system. And some of this hydrostatic pressure is transmitted to the venous end of the capillaries. So as this hydrostatic pressure is now higher, so let's say it goes from 15 to 20 millimeters of mercury, but the osmotic pressure is 25. So even though there's net inflow of fluid back into the capillaries, because the pressure is reduced, the inflow is also reduced. Remember, before the hydrostatic pressure was 15, so the net pressure affecting the inflow of fluid into the capillaries was 10 millimeters of mercury. Now it's 5. Okay, so this is what results in edema, which is accumulation of fluid between the tissue cells, i.e. increase in interstitial fluid. And this increase in interstitial fluid, edema, has detrimental effects on healing of surgical wounds or healing of chronic wounds by secondary intention. Now, let's very briefly discuss the pathophysiology of chronic venous insufficiency. As we already discussed, the incipient event is increase in venous hydrostatic pressure, which is transmitted to the venous end of the capillaries, resulting in increase in interstitial fluid, which is called edema. Increase in interstitial fluid is essentially edema. Now, if this is left untreated, you get endothelial damage and increase in local inflammatory mediators, all the way from tumor necrosis factors to interleukins 1 and 6, MMPs, TGF-beta, and whole host of other inflammatory mediators, which leads to stasis dermatitis, hemosiderin deposition, and if this is left untreated for extended period of time, scarring of the skin, dermal fibrosis, scarring of the subcutaneous tissues, subcutaneous fibrosis. Now the tissues are compromised. The mechanical and biochemical properties of the tissues are now compromised. What does that mean? It means that if you have wounds in the lower extremities, that will lead to chronic non-healing because the wounds are now in compromised tissues. The example I use sometimes to explain it to patients is, I ask them, do you garden? And they're like, well, we do. Well, you plant plants in good soil, right? The plants flourish and they grow. But if you plant plants in gravel or concrete, they don't grow. So your fibrotic scarred tissues are like gravel, and which compromises local wound healing. So if you take patients to surgery and operate on the lower extremities, there's increase in post-surgical complications, including wound dehiscence, leading to chronic non-healing. In order to truly comprehend the effects of edema and its consequences on diffusion of nutrients from the intravascular space to the tissues, we really need to explore Fick's law of diffusion. Fick's law of diffusion says, by the way, Fick's law of diffusion relates to diffusion of molecules through different mediums, i.e. air, water, and tissues. So Fick's law says that flow of a given substance is equal to the diffusion coefficient multiplied by the area over which the flow occurs, multiplied by the change in concentration, divided by the length. So let me illustrate this with an example. Point C1 is within the capillary. Point C2 is the closest cell to the capillary. Point C3 is the cell furthest away from the capillary. So the flow from C1 to C2 is the cross-sectional area over which the flow occurs. Multiply the difference between C1 and C2 concentration for a nutrient, let's say oxygen, divided by the length over which it occurs, L. So what Fick's law of diffusion tells us is that there will be greater flow of oxygen to the cells in the C2 region than to the cells in the C3 region because they are further away. Now, the other thing that Fick's law of diffusion tells us is that the diffusion of nutrients is also governed by the medium through which diffusion occurs, and that's important. Let me illustrate this with an example. D is the diffusion coefficient. The diffusion coefficient of oxygen air is about 6.4 times 10 to the minus 5. In water is 1 times 10 to the minus 9. So oxygen diffuses through air or flows through air up to 10,000 times faster than it flows through water or diffuses through water. And this diffusion coefficient doesn't only apply to oxygen, it applies to other nutrients. And as you can see here, the diffusion coefficient of glucose is lower than that of oxygen. And other nutrients such as vitamins, minerals, amino acids will have their own respective diffusion coefficients. So Fick's law of diffusion tells us if the diffusion occurs over greater length, the delivery of nutrients will be reduced, or if it occurs through a medium which impedes the flow of nutrients, the delivery of nutrients will also be diminished. So we'll use oxygen as an example to illustrate Fick's law of diffusion, but this argument can be applied to any other nutrient, such as glucose, amino acids, vitamins, you name it. So in this picture, you see cells richly bathed in oxygen. At either end, the capillaries supply all the cells with oxygen. There's no hypoxia. In edematous tissues, there's increase in interstitial fluid, i.e. fluid between the cells, leading to increase in distance between the cells and the capillaries that supply oxygen and nutrients. The cells closer to the capillaries may be adequately supplied with oxygen and nutrients, but the cells further away are in the hypoxic zone, i.e. reduced delivery of oxygen. So this is how edema detrimentally affects the flow of oxygen to the tissues. And if one understands Fick's law of diffusion, it all makes sense. But Fick's law of diffusion also tells us the other thing, that the medium of diffusion matters. So in healthy tissues, the diffusion coefficient is not compromised. But in chronic, fibrotic, scarred, woody tissues, the diffusion of oxygen and other nutrients may be further compromised, further compromising the delivery of nutrients to the cells, leading to chronic non-healing of wounds. So here's another illustration of Fick's law of diffusion as it applies to delivery of nutrients. On the left here, my left, as I'm visualizing the screen, you see that the oxygen tension in tissues is about 30 to 40 millimeter mercury pressure. The oxygen tension in a cell is about 10 millimeter mercury. And by the time it gets to mitochondria, it's 1 millimeter mercury. Why is that? Oxygen is diffusing through different medium. So from the intravascular space to the cell, it diffuses to the interstitial fluid. Interstitial fluid is essentially saline with some dissolved proteins. And then once it crosses the cell membrane, it's diffusing through cytoplasm, which is more viscous substance of different proteins and other cellular components. And then it diffuses to the mitochondria. So there's tenfold drop in oxygen tension as it flows across the cell. The oxygen tension of in the capillaries, in the pulmonary system, in the lungs, is about 100 millimeter of mercury pressure. So by the time it gets to a cell and then to the mitochondria, it's 1 millimeter mercury pressure. So the oxygen tension is reduced by a factor of 100. Mitochondria is all that matters, because in mitochondria is where oxygen is used to produce ATP. ATP is the powerhouse of the human body. All our nerve impulses, everything we do is powered by ATP. The heart, the cardiovascular system, the renal system, any system in the human body is dependent on the energy generated from ATP. And that's why we breathe oxygen, to generate ATP. And on the right-hand side, another illustration in a different animal model, the effect of distance. Oxygen tension in the intravascular space, it's about 10 millimeter mercury. In the cells closest to the capillary, it's about 2.7. And a cell further away is 1.3, the effect of distance. So I hope I've used these examples to illustrate Fick's law of diffusion as it applies to delivery of oxygen and nutrients from the intravascular space to the interstitial space and into the cells. This delivery of nutrients is affected by distance and the medium through which the nutrients diffuse. So how do we treat patients? Well, if you look at the pathophysiology of chronic venous insufficiency, we know that even though the incipient event is an increase in hydrostatic pressure, eventually this leads to secondary biochemical changes, leading to increase in chronic inflammatory mediators. However, at this moment of time, our technology is not mature enough to cheaply produce and bioengineer growth factors and other antidotes to these chemical mediators, which can then be applied topically to the wounds to augment wound healing. Perhaps in the next decade or two we'll get there. Until then, we have to rely on traditional approaches. These traditional approaches include addressing the underlying disease process. So if your patient has heart failure, treat heart failure. They may require diuretics. If your patient has kidney failure, treat renal failure. They may need dialysis. And as for chronic venous insufficiency, use compression therapy, and that's another different talk altogether. Elevate the legs to reduce edema. The effect of all these therapies is to improve tissue viability by reducing interstitial fluid, by reducing the secondary effects of chronic edema, which is increase in inflammatory mediators, leading to secondary changes in the tissues, including dermal and subcutaneous fibrosis, which further compromises the integrity of the tissues. So if we early on address edema, no matter what the etiology, we will over time improve our outcomes in terms of wound healing, in terms of post-surgical outcomes if you're operating on edematous tissues, and hopefully this leads to optimization of patient care and patient well-being. I hope you like this presentation. If you do, give it a thumbs up, subscribe to the channel, and I'll talk to you later. Bye for now.